Okay, looks like it slowed down. So welcome, everybody. This is the ARC of Pennsylvania's initiative to address COVID-19 health disparities among people with disabilities, Lunch and Learn. So if you've been through with us through this incredible journey over the last 2 years, we have been working with the Department of Health on a grant around the issues that people with disabilities faced during the pandemic. And what we all know is the many of the disparities and inequities that occurred really were happening prior to the pandemic. So the pandemic kind of pulled that curtain aside and really allowed us through this work to elevate it and obviously to continue to work on it. So the grant was divided. We had a health disparity task force, which helped guide the project, as well as our regional community work groups. And our regional community work groups were through our chapter network. So we were very fortunate to have our chapters throughout the state to bring together local community leaders in the health field to work on these issues that we were bringing up during the research. We had over 400 individuals with disabilities, family members, caregivers, health professionals across diverse ethnic, racial, rural population. And the voices that we heard and the stories that we heard can be seen in our solutions report if you've seen that and you scan the QR code. But it also, we wanted to make sure that people with lived experience told their story and that we were able to elevate that story in our report. Like I said, this whole thing was funded through the Pennsylvania Department of Health through a grant through the CDC. Today's focus, if you've seen the report, we have 10 core recommendations. Today's focus will be on core recommendation number 6, provide disability person-centered training for healthcare professionals. Today's agenda, we will talk about the health disparity and recommendation, and then we have a practice panel. You will hear from people who are actually providing or developing that person-centered training for healthcare professionals. I'm going to turn it over now to Emma Nolan, who is our manager of our health initiative, and she will be telling you more. So take it away, Emma.
Thanks, Sherry. Before we get into our practice panel today, I just want to give a little bit of background information on how these Lunch and Learn series came to be and the work that the ARC of Pennsylvania ourselves are doing in terms of health equity. So we have a grant from the Department of Health, as Sherry mentioned, that started about 2.5 years ago at this point. And we are really looking at COVID-19 healthcare barriers and then also developing a set of recommendations. So all throughout 2021 and 2022, we held a COVID-19 healthcare strengths and barriers listening tour. And we asked 2 main questions to over 400 people across the state. And that was what is working in your area? What are strengths in your area that have led to increased access to healthcare for people with disabilities? And then the main question was, what are the barriers? So what prohibited you or your loved one or anyone you know from seeking equitable healthcare and that might have led to worsened health outcomes? So in these conversations, we had a lot of different diversity by role. So we had people with lived experience of disability, caretakers and family members, as well as professionals in both the field of disability and healthcare included in all of these conversations. We had intentional outreach across all disability types, as well as race and ethnicity and location as well. From all of these conversations, we developed this tool right here that you will see categorized by social determinants of health. And a social determinant of health is something that affects your health in any way. So it could be where you learn, work, play, worship, live, any of those categories that affect your health in some way. So today in our practice panel and in this Lunch and Learn, we're going to focus on those 2 arrows that you see on the right-hand side of the screen pointing to systemic healthcare barriers and staffing barriers. And these really manifested themselves in things that happen when a healthcare professional doesn't have the knowledge or the education or experience to treat and interact with patients with disabilities. And during our second year of the grant, we focused on those solutions. And in that solutions report, we have a wonderful tool of QR codes where we interviewed some of our participants and spoke about their actual lived experience and why this recommendation means so much to them. And this is just one of those examples that really highlights what we're going to be talking about today in the practice panel. So this is from Marjorie Anderson, who is the parent of a beautiful, unique, and magnificent daughter with Down syndrome and intellectual disability. And we are going to play a short clip of something that is included in our solutions report.
For testing also, it was a challenge. It didn't seem as though the staff were prepared or considering that she had an intellectual disability before administering any of the testing for COVID or the vaccine for COVID. She made it through, though. It was a challenge. But it was stressful also for me as a parent to try and support her. Training, professional development, and awareness for providers would be helpful so that, they're able to meet and serve everybody and understand how, everybody has unique needs and that they're able to, associate, with people with, disabilities as freely as they associate with people who do not have disabilities.
So that was just one of our 10 QR code speakers that we have embedded in that solutions report that really highlight the need of why this recommendation is so important. And as Sherry stated earlier, this recommendation is number 6 in our report, and it reads, provide disability person-centered training for healthcare professionals. So a little bit about what this recommendation really talks about and might look like would be train medical professionals, mental health professionals, support staff, government officials, employers, law enforcement, community organizations, caregivers, and family members. And all of this would also address the intersectionality of disability with culture and ethnicity and mental health. We need to include people with lived experience of disability and their families as the designers of these courses and or instructors of these courses, working alongside the academic institution to make sure that their experiences and their lived experience are really included in this curricula and highlighted. We put together just a short list of what we think the standardized curricula should include, but of course is not limited to. So we need to highlight the importance of plain language in medical settings and terminology basics, as well as including information about the history of medical mistreatment of people with disabilities and why there might be some mistrust of the medical system within the disability community. Legal obligations and responsibilities for caring for patients with disabilities, whole person-centered healthcare approaches. So making sure you're not looking at disability from just that medical model lens of trying to treat a disability or fix a disability. Behavior as communication. So this is important for people who may not use words to communicate. Of course, trauma-informed care is important, as well as identifying ways to have effective communication with the individual with the disability and making sure you're communicating in ways that they can grasp and understand, and not only talking to their parent or their caregiver or support staff, but identifying your questions to the individual themselves. So I'm going to turn it over to our facilitator, Rhonda Beach-Tyree, to bring us through a few things that are already happening in resources and practices before we get into that practice panel today.
Thank you, Emma. You know, one of the things that really excited us was how many strengths we heard about practices that are already underway, including this topic, disability-specific healthcare. You can do an internet search and find a lot of practical tools. And again, there are a lot of organizations already practicing training. You're going to hear from two of those key entities during this panel presentation, but we want to highlight a few, and we'll put a tool in the chat with lots of links. The Philadelphia Coordinated Healthcare Organization provides an extensive 80-minute webinar, for example, on health conditions, healthcare for people with Down syndrome, and it provides a whole person health perspective and specific health conditions and care needs of individuals with Down syndrome. Or another example is Disability Etiquette, which is a tips tool on interacting with people with disabilities that's provided by the United Spinal Association. And there are similar tools out there from other organizations. I know Temple University Institute on Disabilities has an etiquette tool. And another tool that's powerful are the resources that are available through the Centers for Medicare and Medicaid Services. For example, they have resources that can be handed directly to providers or to used in trainings and in services and professional development for healthcare associations that are about improving your communication access for populations like those who are blind or have low vision, or those who are deaf or hard of hearing. And they have tools on things like improving physical accessibility and modernizing your healthcare setting, as well as tools directly for individuals with disabilities to elevate your voice and get the care that you need. And other practical tools can be found like these from the Boston Medical Center, but there are all sorts of organizations that have social stories that are really good for preparing individuals, especially those on the autism spectrum, for medical procedures. And you can see all sorts of topics there, like preparing for a dental appointment, or wearing a face mask, or what's an EKG and what will I experience when I have that experience. And then there are organizations that have done work on really trying to pull together more systemic, standardized curriculum. For example, this is a group in Ohio, the Nysunger Center at Ohio State University, worked with a group called the Alliance on Disability in Healthcare Education, and pulled many organizations together to look at what core competencies would be in a standardized curriculum. And they're working with the Accreditation Council on Graduate Medical Education in Ohio to advance that work. We have a lot going on. One thing we're really excited about is that the Health Resources and Services Administration recently announced more than $8 million through 18 awards that they gave nationwide, and 3 of those are in the Commonwealth of Pennsylvania at roughly $600,000 each. 3 of our institutions at the Albert Einstein Healthcare Network, Thomas Jefferson University, and the Wright Center for Graduate Medical Education received awards where they will be looking at curriculum for language, linguistically appropriate care, and also disability-specific care. And we recently heard about the Edith L. Trees Charitable Fund that gave $1.5 million to Duquesne University, who is pulling forward and hopes in 2024 to start their first coursework and clinical rotation of medical students in serving individuals with disabilities. And we may have some of those individuals on our call today. I know they registered. That's just so exciting. As well, there are training programs already that elevate individuals with disabilities as trainer. The Pennsylvania Academy of Family Physicians has a program, PDAT, Patients with Disabilities as Trainers, and so does Lehigh Valley Health Network have that model. There are also really exciting things going on at Penn State in their dental program. They have a personalized care suite that really has accessible accommodations, and medical dental students rotate through that while providing clinical care that is appropriate for individuals with disabilities. And there are many others, CHOP and Geisinger and Temple. You know, a question that we continue to ask is about how to be systemic in providing disability-specific care so that we ensure statewide equity, that every individual is able to access qualified providers. It's my pleasure to introduce our panel today. They're here to share some ideas about what it looks like in practice and hopefully continue to inspire what each of us can do. I'll invite Shane Janik, who is Executive Director of the ARC of Philadelphia and has been a key leader in this initiative in the Philadelphia area in advancing the work we're doing here, but also some really exciting work on health outreach project. This clinic is the first medical student-run free clinic dedicated to serving intellectually disabled adults in the country. And Shane, I'll invite you to introduce Valerie and Mike if they're with us. And then we're excited to have with us Lydia Smeltz, who is a medical student at Penn State, and she's here to share with us a pilot study that she and other students led at Penn State at looking at a really powerful model called Adept Care. Welcome to both of you. Shane?
Hey, hi everybody. Wonderful to see a lot of our friends being highlighted in the intro here with Rhonda. It's awesome to see. I'll share my screen here, and I'm joined by our Health Advocacy Director, Valerie Chadwick, is on the call too. Valerie has to jump off around 12:30, so I'm gonna let Valerie do an introduction just for herself, and then I'll take it back over for the presentation. But just wanted to join to say hi. And Val, you have to run because we actually have Temple Medicine, a student group coming in at 12:30 at our facility. So we didn't want to reschedule with them. We try to be accommodating to all the student groups. So kind of an example playing out right as we get to chat about the program with everybody here today too. All right, so let's share my screen. And Val, I'll let you take it over for an intro and pass it back to me when you're done.
Good afternoon, everybody. My name is Valerie Chadwick. As Shane stated, I am the Health Advocacy Director here at the ARC of Philadelphia. I work directly with our Health Meet program that we'll kind of be touching on today as well. A little bit about my background and how I even got connected to the ARC. So I am a nurse. I have about 15 years of experience between intensive care and hospice care, between home and inpatient services. And the one thing that led me to the ARC was the fact that I did not receive education or training in my nursing schooling that prepared me to care for people with disabilities, specifically intellectual and developmental disabilities. So I sought out for that opportunity to get that experience on my own, which is how I got connected to the ARC, specifically the Health Meet program that I actually help to run now. It's been so beneficial to be on the other side. So knowing the deficit, being able to experience it firsthand, but also being on this side and being able to help bridge the gap and fill areas of deficit in medical education to ensure that people with disabilities get the same quality of care that we're trained to give everybody else. So it's an honor to do this work. It's an honor to be connected to the ARC. It's an honor to serve the intellectual and developmental, the IDD community in this way, and even just give back when it comes to medicine and education and things like that, and preparing those who are coming out of school and into practice to make sure that they have what they need to provide quality care for people in the IDD community. So yeah, just appreciate the work that we are all doing collectively together, and looking forward to the progress that is to come. So thank you.
And we're really excited to have Val join the team. I think we're about 4 months in, but as she mentioned, had volunteered with us in the past. So it's been an awesome start as she takes over the program, and we're really excited of what can come from here. So We'll jump in on really just discussing the program from here, and we try to really provide information for anybody that's first interested in modeling different types of initiatives around healthcare advocacy. And so the discussion is really what we find works to get our foot in the door to even have the advocacy opportunities and conversations. And then how we do that specifically with our university partners. And then towards the end, I have a section that's what we actually deliver with the students that work in our program. So we'll be able to show you some of the content that we're also delivering at the end as well. So I'll start jumping through. All right, so our mission, we share the mission across all our chapters, and this is the rest of our team. We've yet to get a group photo with Valerie, so we got to get a new one up here. But always want to start with our mission, and we'll get into any details here, but just that shared with all our chapters. And then jumping into our program. So we actually started this healthcare advocacy program about 9 years ago, before I began. And I think in the description, Rhonda mentioned the description for the health outreach project was the first student run initiative that gets this education. So it was maybe 9 years ago. It is no longer the only, so which is amazing to see in the field evolving very quickly since that time. And just as Emma and Rhonda had laid out, really addressing the areas of need around providing the educational opportunities specifically to medical students is how we began, and we've since started to branch out to other programs and other health related degrees. So nursing and rehabilitation sciences and dentistry, etc. So we'll touch on that as well. But ultimately, as an advocacy organization, our goal is to mitigate disability bias through this program. So what you'll hear me say a couple of times is that we're not coming in to teach clinical skills. We're not clinical providers. And I think at times there's a hesitancy in the advocacy field to maybe not want to jump into this space because of that, feeling that it's a place for clinical perspectives and expertise. Also liability issues that we're very well aware of. But if we can come in and have this impact when we're talking about mitigating biases as opposed to providing clinical teaching and skills. So in fact, a lot of the partners who are physicians and other healthcare providers themselves have come around to us to say that they need us to come in to provide this education, which was great. So they were really opening the doors and creating that, giving us that welcoming feeling about, we need you to actually come and teach med students. Our healthcare professionals didn't have this training or don't have these experiences. And so they really helped to alleviate any of that hesitancy about getting involved in healthcare advocacy in general. And then our secondary goal, while we engage with these students, we also want to start the conversation for them around what the disability services field is. So a lot of times when we work with students for the first time, they're not familiar with what home community-based services are. We know that HCBS and healthcare can be perceived as almost sometimes like the same from the public, but we know they're very much separated and differentiated. And so what are the gaps there between healthcare delivery and home community-based services? And so we start to initiate that conversation with students as well. And you'll see that we'll do that by partnering with HCBSs that we're affiliated with. And I want to mention too, so we began this 9 years ago, and it really was our board of directors made the decision to keep this program moving along because of our geographical leverage that we should be taking advantage of in our region. So we do have 4 medical schools, 2 dental schools, a podiatry school, a dozen nursing programs, you name it, out of Philadelphia, let alone the internationally renowned healthcare network. So just our position on the map, we really felt that as a local chapter, we wanted to jump into this work and continue doing that in years past. So really excited to be here and keeping it going. This is researcher Lisa Iazzoni. Many people familiar with the health advocacy space, you'll definitely come across their research team. This is just one study that had come out recently that really talks about the social and attitudinal barriers to care. This study was physicians anonymously reporting to these questions asked. So I'm not going to read through these stats here. You can see them, but really just jarring numbers, eye-opening numbers here. So we know that the literature review behind all of this work has become very established in recent years. So we can lean on that from the research world as we back up the need for this advocacy work. All right, and then the statement of need, again, actually related directly to the recommendations report. Why we were brought in is that our program was designed to address the lack of required education in all of these different health degree programs. So that's where we're really trying to intervene with the purpose of advancing health equity for this population, again, introducing future healthcare professionals to home community-based services. And it creates an opportunity to focus on a population of interest from the university's perspective. So we're trying to get them interested, understanding the reasons why this is important, and then provide them with a solution and a partnership with us. I will mention that we started with students, so this future healthcare workforce, but this does not stop with students. We can absolutely expand this out to practicing healthcare professionals. All of the content's generalizable, and we know that there's an area of need with our current healthcare workforce as well. So through our program, what we really are trying to see is an increase in students' confidence, comfortability, and preparedness to work with this population. So again, talking about how we're specifically trying to address disability bias in order to achieve these outcomes with these variables, and again, not teaching towards clinical skills. We do a pre and post survey. We do see the shift across these three variables with our students, which is awesome to see. It is only one point in time. We've yet to do a long-term follow-up. But over the years, we do see a very significant jump from just visiting our facility one time, conducting a few screenings with our participants with IDD, and then seeing that difference as they leave the facility the same day of. And then for universities, so this is more, one, what they get out of it, but two, also strategies of how we market the program and get universities to buy into doing this advocacy work with us, seeing the importance and then seeing the value for them. So first, we'll pitch this to universities as staying ahead of the curve of required competencies of disability education. So we know for the medical programs, this population is not a requirement for students to get experience with. We've heard statements from academia that one, the curriculum is already packed. It's difficult to put anything new in it. And that two, between the requirements of mental health, pediatrics, and geriatrics, they feel that generally disability and intellectual and developmental disabilities probably covered in there. And we said, that's great, but definitely not good enough if something's probably covered. So this is a way to stay ahead of the curve for required competencies. And specifically what we're citing is, we know that the accrediting bodies in the US are having this conversation about the population with IDD. We know that CODA, the accrediting body for the dental programs, did pass this requirement, I think 2018, 2019-ish. So all of our dentistry programs have to get their students this experience with people with IDD specifically. And we do see this shift in really seeing like it's only a matter of time until the accrediting bodies for medical programs are going to jump in, make that same decision as well. So we're pitching this as, when that decision comes down, instead of scrambling to put together something and become compliant with these required competencies and having to find community-based partnerships who are the doorway or gateway to the community with IDD, like the ARC and other advocacy organizations or the HCBS field in general, you can be ahead of the curve and be able to jump right in when the word comes down for any changes in these required competencies. And the second one that we're seeing a lot of momentum around is really the conversation about building disability into any DEI initiatives for that university. So sometimes it's not with medical schools specifically, it could be a university as a whole, but that really gets our foot in the door. And that is a priority across all programs. And so we've been able to gauge interest and really jump into these partnerships very quickly when we frame this as a DEI or DEAI initiative with programs. So really, same things going on, just how we frame it to get buy-in with partners. And these have been two strategies that have worked for us in recent years. And then who our partners are. So I mentioned we started with medical programs this past calendar year. We're really excited about that. We actually work with all 4 medical programs in some capacity for the first time in the history of the program. So We've worked with 2, then 3, and maybe 2 in a year again. But this past year, all 4, it was awesome to see, and really exciting for what's to come. And then I mentioned too, this content is generalizable for any related program in healthcare. So we even had public health students come through as field work placements, graduate and undergraduate nursing, rehabilitation sciences, dentistry as well. And this is how we pitch our program models. So we know we are connected with home community-based service providers. We've made friends and have a really strong network of healthcare providers who specialize in seeing this population with IDD. And we connect the university partners. So we bring all 3 of these parties together for the university. And that's, again, really the coordination, the network, and then the delivery of the program falls on us in the middle. And I believe who we have, some of our partners here. This is towards the bottom. So the Jefferson Fab Center, the Penn Personalized Care Suite. You heard Emma and Rhonda mention them earlier. They'll be presenting in this series as well. So they just happen to be out of Philadelphia, but amazing work and amazing people there. So please keep joining this series as we move forward, and highly encouraged to attend those sessions for sure. But when we do this work, so we do have self-advocates involved. We have members on our team. We also invite other advocates from other organizations across Philadelphia to join to give this experience to students. We do try to target disability champions with the internally to the university. So really finding faculty and administration that we'll hear are a family member or a parent or a sibling of somebody with IDD, and then they have a voice internally with the university, and they kind of get the ball moving for us. And we've had a chance to also befriend and again kind of join in a network of specialists that primarily see people with IDD or have a level of expertise working with people with IDD. So people like developmental pediatricians, medical geneticists have a background with rare syndromes and things like that. So we try to keep this network very well connected. We're on a few committees with all of these organizations and practices. And then when the opportunity comes up to introduce our network to students, we take advantage of that opportunity. And then what our program is actually delivering. So we do deliver observational health screenings. We deliver about 50 students come through our building a year. We're anticipating that to break 80 now that we have 3 medical schools with fixed schedules rotating through our facility. But in the past, about 50 students, 80 screenings with 50 people with IDD. I mentioned those are observational. So to get around the regulations where we're not allowed to provide care on site, what we can do is do an observational assessment and kind of provide health promotion about what our participants have conversations with the medical students that visit our site. So for example, we'll do a whisper test to evaluate hearing. And it's really just if somebody can hear on both sides of their ears. People that wear glasses and contact lenses, we have conversations about how they think their vision is. And if they mention they haven't had a new pair of glasses for 5 years, we mention, well, maybe it's a good time to check out or look into a new prescription. And here's how you can have that conversation with somebody at home. Other areas, maybe some people like us to ask us to look at their feet, and sometimes there's findings of dry skin, for example. So again, we're not providing care, but noticing somebody has dry skin, and then we use that to prompt a lesson around why moisturizing is important for dry skin. So these observational assessments are very, very basic, and they allow us to we're allowed to deliver those in an HCBS facility because we're not providing care. And the universities allow their students to do it, again, because they're not learning a clinical skill. It's more of a health promotion type of assessment. So again, that's kind of how we have to frame the actual interaction to get the buy-in and the approval of both parties there. And that's worked out great, again, for the 9 years that we've been doing this. So in addition to the health screenings that we bring in, 1 or 2 students at a time to work with 1 or 2 participants with IDD at a time, we also deliver discussion panels. This is more about anybody that will have us, wherever they need us, will show up. And we bring a panel of self-advocates, family members, and then healthcare providers who are have an expertise working with people with IDD. So that's when we tap into that network and bring these folks together. The panels is delivered in a way so that our audience is getting a provider's perspective, a support person's perspective, and the patient's perspective all in one room. These generally branch out into Q&As towards the end that are super beneficial for the group, and we get a lot of interest, even at presentations of 300 students or more at orientation or like Doctoring 1 courses that are required to take. We see a lot of engagement for about half an hour after we deliver some of the content. And then in general, we hit about 8 presentations and hit about 500 students per year. And then finally, we do have some field work placements at our facility, mostly with occupational therapy and other rehabilitation sciences, but also some nursing programs as well. So this is that assessment that I mentioned. So this is what our med students are walking through with our participants. You'll see, again, very basic vitals, height, weight, respiratory rate, and then again, a hearing test. Oral health is just looking at somebody's teeth and asking about their visits to a dentist. And again, we're not providing any medical advice or a clinical assessment here. And what we'll do with student 2 is, working through this form, there's not a requirement to complete this form. So if a participant wants to just spend time talking about their oral health and their teeth, we'll spend the full half an hour just doing that. So it's a very low pressure, comfortable environment that we try to create so that the benefit is really the social interaction between the student and the participant with IDD. And then, like I mentioned, this content, all generalizable, really across all programs. I touched on these points here, so I'm going to move along here. And then, yeah, just to conclude, so really we're supplementing healthcare education and bringing disability awareness, but with this vision and goal to decrease biases so that we can enhance the quality of care. So we do frame that in the learning objectives to universities, so they have an idea of what their students will be learning up front, and again, what the purpose of the content is and how it's designed. I will mention too, I think back on the slide about getting buy-in from partners, we've also had a lot of momentum around targeting community health. So that's been a kind of where we see a lot of opportunity happen very quickly. So while we kind of talk about curricular changes, that's very much high-hanging fruit, and that takes many meetings with many admin and faculty. But we do find, if we find a faculty that oversees community health initiatives, they may want to jump in with us like next semester. So we're figuring out, again, kind of the language that the university speaks so that we can speak that with them and get some buy-in more quickly than maybe we have in the past. So that's been great as well. So I only have like 3 more minutes. I'll go to 45. I'll touch on what some of the content is in that presentation that we deliver to every student that comes through our facility and in those discussion panels that I mentioned. So this is just some snippets that we have. Here are the learning objectives that really is the agenda of our presentation. The need for healthcare advocacy, why it's important, historical context of disability medicine, importance of HCBS, identifying health disparities and inequities, what the social determinants of health are and how they may apply to the population with IDD, and then strategies for providing inclusive care. Interesting, Emma and I, we did not coordinate this at all, but a lot of these mirror exactly what the report was up to the stage. So the recommendations report includes a handful of these on what a curricula could be considering, which is awesome to see. So we'll touch on the historical context. We do start with institutionalization, talk about other relationships modern day about quality of life metrics and patient autonomy. Really gets people thinking about how does this apply to me as a future practitioner. And then we also use this as a prompt to talk about HCBS, moving from institutionalization to HCBS, and then how HCBS generally reflect the social determinants of health. So We know that we have disability services across residential, day programs, home and community hub, supported employment, etc. And if those systems aren't up to par, then we know that they would directly influence health outcomes over somebody's life course. We talk about the statement of need of background, which is all of the same background as the recommendations report and what we're all familiar with. But again, using this as prompts to get students interested in kind of understanding again why this is important. We bring up the Fatal Five. We find an audience is very interested in this. HCBS providers very familiar, but healthcare providers, this is not a recognized term for them. So this is very much siloed in disability services and not in healthcare yet. So we'd like to make sure we keep pushing that along. We talk about the medical model of disability, and then how that contrasts with the social model of disability. We walk through some examples, and we try to touch on examples that go from things like the individual interaction with somebody, like communication barriers, up to things like the organizational and policy and practices that are also inaccessible. So things like why are insurance companies only allow a PCP to bill for 15-minute increments to see a patient? So just that policy is designed for a quote unquote typical patient would not be designed for somebody that requires more time. So just the inconsideration of people with disabilities in establishing this 15-minute billing unit is something the social model of disability would push up against and just blatantly call out that inaccessibility. And we touch on what some inclusive practices can look like. This top left is a snelling chart for pediatrics. We use that as an example for a population that maybe has limited to low literacy skills, that maybe you'll get more accurate results using a snelling chart with shapes for a vision assessment. And we use these examples as prompts to think of how creative and flexible and accommodating that you can be as a provider that turns into inclusive practices. And then lastly, we do bring up the diversity of disability and identity, and we touch on, while our mission is for people with IDD, and there is a spectrum for intellectual disability, and how the community overlaps with many other communities, we also make sure that we bring up disability as a whole, and talking about how all these different communities with disabilities should equally have their own content and presentation. Some things are generalizable to other communities, and some of the content that we deliver may not be at all. So just to really, again, widen the scope of the audience is kind of like understanding and getting them interested into the range that this content can affect. So I think that's everything. Yeah. So it's a little bit about our program, some things that we found work well with our partners, what we actually deliver with our students, and we'd love to hear from anybody. So just reach out afterward. We're connected with this network, and the ARCA PA is doing awesome and also amazing job keeping us all connected as well. So thanks for having me. Hope to hear from anybody that's interested, and I'll turn it over to Lydia.
All right, thanks, Shane. I'm excited to follow you as I feel like we have a lot of complementary work going on. So excited to continue this conversation. My name is Lydia. I'm a third-year medical student at Penn State, and I'll start with a brief visual description of myself. So I'm a white woman with blonde hair, sitting in my home office with a white door in the background. And today I'm going to talk to you about implementing adept care as a novel teaching tool to improve medical education. So a little bit different than what Shane discussed, as we've actually been able to implement the curriculum directly at Penn State. And I'll share some tips about how we were able to do that, because as Shane alluded to, it was not the easiest process, but we made it happen. So just some brief disclosures. We do receive funding from the Alliance for Disability and Healthcare Education, who the ARC mentioned earlier in this presentation, and also the Woodward Center, which is an internal funding source. We've been thankful to have 2 publications related to what I'm going to talk about today, and that's really important for dissemination, which we'll talk about a little bit later in the presentation. So I like to start off by thinking about why we're all here, and we're privileged to be in this virtual room with a lot of people who already care about this topic, and that's really important. But it also always makes me think about who needs to care and isn't here. And so I hope that I'm able to strike the balance between things that make you think and things that you are already passionate about. So we're going to talk about how the Adept Care protocol was developed, an overview of what that protocol is, how it was implemented at Penn State College of Medicine and Penn State Health, our initial results, and kind of where the next steps are. So a little bit more to qualify and quantify what is the problem. As Shane mentioned, there are no standard training requirements for medical students about disability, which is really frustrating, but thankfully there have been a lot of student advocates and allies who are doing great work to directly address this. And a study from 2019 found that about 52% of MD and DO schools included what was defined as disability awareness in their curricula. And importantly, this disability awareness curricula had a wide range of things, from one-time interventions to longitudinal curriculum. Some of them were focused on a specific subtype of disability. Some of them were more broad. So people are out there doing the work, and there's definitely a need to understand what is working and how it can be amplified. Another study found that 80% of med students at one institution felt that their disability education was inadequate. So these were graduating fourth-year medical students who were becoming physicians about to start residency, and they just felt unprepared. And specifically, they were very uncomfortable doing the history and physical exam for a patient with disability, which is a huge part of what we learn to do in medical education and a huge part of what drives clinical decision making. And this would become relevant as we talk a little bit more about Adept Care. And while there's a lot of resources out there, there's a lack of standardized and comprehensive resources that are widely used. And it's awesome to see everybody putting things out there, but then it's hard to know what is being used and who's receiving what education. And so the goal of our work here was to develop, pilot, and evaluate a novel teaching mnemonic called Adept Care for performing a comprehensive history and physical exam for disabled patients. And if you are new to the medical education space, we love our mnemonics in medical education. I feel like there's a mnemonic for everything I need to know. And so this was a natural tie-in of how we could kind of take all this information that exists in the literature and exists from advocacy groups and kind of distill it into this easily accessible one pager about, if this is the only thing you learn, we hope that this provides a satisfactory platform to get you started. And so we developed Adept Care, a team of 5 medical students from across the country representing 4 institutions. And very importantly, within the core 5 medical students, some of these medical students identify as having a disability, and this was incredibly important. I know we all can agree how important this is. It came up in the plenary introduction, but this work is important because it has been informed by the lived experiences of those with disabilities. And we also saw feedback from physicians with disabilities and patients with disabilities as we refined and continually refined the mnemonic. Earlier in the session, we also talked about the Alliance for Disability for Healthcare Education core competencies. And we use those core competencies when we were defining the different letters of the mnemonic. And we strategically made sure that we hit different competencies within their different sections and that there was a wide range. We also used materials from the National League for Nursing to inform the mnemonic. And ultimately, we created this mnemonic, Adept Care. And so I just want to pause here because it can be really overwhelming as a med student. I often feel like I don't have a lot of power or influence, but through this initiative, I've learned that med students are capable of creating change at their own institution and at other institutions. And so I just want to encourage everyone that this advocacy work is difficult and often exhausting at times, but you can make a difference no matter what your role is. It's not too small. And I think another important thing to highlight is I mentioned there were 5 med students across 4 institutions, and across those 4 institutions, Adept Care has been implemented at different levels. So it's fully implemented at Penn State. It's been piloted at the University of South Florida. It's been implemented at UConn, and it has not yet been implemented at Duke, but we have a student from Duke School of Medicine who has been involved. And so even if the red tape at the individual institutions have prevented the students from having the same impact it's had at another school, they've been able to have an impact. And so I think that is a strength of our team, is just working collaboratively, and we're all passionate about getting this work out, even if it isn't able to get out at our own institution super quickly. So I'm going to walk you through the mnemonic, and this full table is published. We were able to publish the results of this study, which, as I alluded to earlier, is really important for dissemination. So it's great if we create a tool. It's great if we show that the tool works, but if no one ever sees it, then it only has limited impact. And so a key avenue for dissemination in healthcare and in medical education is research. And so we were able to publish this study in the Disability and Health Journal, and we've been able to reach people across the world. Literally, I had to email it to someone in a different country, which was an awesome feeling. Just being able to disseminate this in an approachable way for our community has been very impactful. And so what we did in this table is we defined each letter of the Adept Care mnemonic, and each letter stands for a different recommendation. And broadly, this is supposed to be a teaching tool to help medical students have an idea in mind of how to approach a patient with a disability and obtain a comprehensive history and physical exam. And it's purposely broad to encompass a wide range of disability types. And next to each recommendation, we have the description or problem representation. So why is this our recommendation? What is the research? Why does this matter? And what I think is in many ways most helpful, on the far right, we have sample questions or statements. So you might tell a med student or a healthcare provider, you need to do this, but it can be very difficult to translate that into clinical interaction if you don't have the words to do so. And so we explicitly design these questions so you can memorize them, you can write them down, and you have an easily approachable and appropriate way to get that information. So the first A of Adept Care stands for ask about access needs and accommodations in the healthcare environment. And so this is asking things like, what access needs do you have when you're coming to the clinic? Were you able to schedule your appointment in a way that worked for you? The D stands for defer to the disabled person. So this includes many aspects of language. How does that person describe their disability? What language do they prefer to use to talk about their experiences? The E stands for engage with the patient. And this is a big one. As we talked about earlier, there's a lot of resources for how to do this, but generally speaking, we have focused on making sure you're talking directly to the patient, only using collateral as needed, identifying what are their preferred methods of communication, and saying that it's okay if you don't understand them and asking them to try to explain it again, or similarly, if they don't understand you, trying again to explain it in a different way. The P stands for promote participation and patient-centered care. So again, talking directly to the patient, making sure they're comfortable with whoever else might be in the room with them if they were assisted at their visit by someone, asking before you touch any of their personal devices. T stands for take time for a thorough medical history and physical exam. So making sure that parts of the physical exam aren't skipped. If they need help transferring from, for example, a wheelchair to the exam table, making sure there's appropriate staff training to be able to do that. And then transitioning to the care part, C stands for consider disability-related conditions. And this is one that our team who created this is really passionate about. So we talked a lot about there are some conditions that are directly related to your disability. So for example, people with intellectual disabilities are at a higher, have concurrent psychiatric conditions at a higher rate than people without disabilities. And so it's important to screen for that. But there's also things that people with disabilities have that people without disabilities have. For example, heart disease. although we find it in people with and without disabilities, we know it's more prevalent in people with disabilities due to less screening. So making sure that you are not only asking disability related health conditions, but also making sure that you're aware of those associations so you don't forget to ask something. Additionally, asking things like safety, as we know that people with disabilities are at a higher rate or experience abuse and neglect at a higher rate. The second A stands for ask about access needs and accommodations in the home and the community. And this directly targets the social determinants of health that we were talking about earlier. So making sure they have the appropriate accommodations and equipment at home, they're able to access what they need to live a healthy life. Because something I try to remind myself of often is the social determinants of health actually account for 80 to 90% of someone's health and health outcomes. And so what we do in the clinic, we feel like is super important, and it is super important, but it only has about a 10 to 20% effect because people don't live in the clinic. And so addressing these social determinants is really important. The R stands for review the treatment plan and respond to feedback. So at the end of the visit, just taking a second to check in with the patient, seeing if they have any feedback of something you can do better next time to make the visit more inclusive or accessible to them. And the E stands for ensure accessible follow-up and referral. So if I'm the provider and I'm recommending the patient gets a mammogram, but they're not able to stand, that's going to be a problem because they're not going to be able to get their mammogram. And so maybe I call the imaging facility and ask what accommodations they have, or we just have a communication about where have you gone in the past for these services and was it accessible for you, to try to be proactive and eliminate some barriers. And I just want to zoom out a bit. As we talked about earlier, these things don't happen overnight. And so I think it's important to provide some overarching history of how this came to be, what we've done in the past, and where we are now. So 2 students at UConn had the initial version called Adapt Care, which they had piloted at UConn in early 2021. And then in July of 2021, we started forming the student team of the 5 students across 4 institutions. And we took what they had, but did significant revisions and refinement to create the Adept Care version. And we got feedback from individuals with disabilities, providers with disabilities, which I think is something important to highlight because we often are talking about people and patients with disabilities, but we don't often think of our colleagues who have disabilities. And so having this variety of levels of experience was really important to us. And so we launched the Adept Care as part of a disability health elective at Penn State for first-year medical students in spring of 2022. And that was the pilot, and then we did it again for the next year's class. Then we analyzed those results from June 2022 to March 2023. And then I'll talk about this a little bit more in the next slides, but we implemented Adept Care with the patient-facing staff at Penn State Health. And so this early involvement we did with the med students was a sounding point or a jumping point for us then to be able to say, hey, this works. Can we share it with more people? And so as we talked about earlier, it's great to get this information to students, but there's a whole generation above us who never received this education. And so we're very fortunate to be able to provide that education to them. Because we were so successful with the elective curriculum and the staff curriculum, this education has now been incorporated into the mandatory curriculum for all second-year med students at Penn State, which I'm very proud of. And I think the other key pearl here is that when I started, I wanted this in the mandatory curriculum straight up. I'll own that. And I was told no. So I went for the second best option was, okay, well, can I do it as an elective? And some people will take it. And so I could have said, okay, this didn't work out. I don't know what I'm going to do now. But by taking a step back, saying what would be the next best option, I was then able to earn the opportunity for this to be implemented into the mandatory curriculum. And so I think it can be really easy, especially as a student, to be sucked in and have this narrow vision of what success looks like. But when we zoom out and we play the long game, we've been able to have a lot of success. And while that can be earlier in this 2021 space, there's not much happening. As you move to the right of the screen, you see how much we have going on, and that has been very encouraging. We've also implemented this into the mandatory curriculum for the physician assistant students, and we're continuing to evaluate everything that we have going on. And excitingly, we're now working on phase 2 of the adept care videos. So as I mentioned, we have this mnemonic. We have this mnemonic recorded as a teaching video, which walks through each step as I described for you. And then we also have a second video that shows adept care in action. And so it's a standardized patient situation with someone who has a spinal cord injury as her lived experience. And it walks through each step of the protocol of what it would actually look like in real life. And something we found out during the implementation is providers wanted more information about how this would look like if the patient was a pediatric patient or if the patient had an intellectual or developmental disability. And so in these phase 2 of the videos, we're doing just that. We are filming scenarios with a pediatric patient with an intellectual disability and with a patient who has cerebral palsy but has some speech differences. And we've done that through collaboration with the ARC of PA. So we're very excited to roll those out. And so just a brief table about how this has been implemented. So on the far left column, in spring 2022, when we did our pilot with the first year medical students, we had about 33 participants, 33 pre-surveys, 21 post-surveys. And this is the paper that we published that I showed the table from. Then, like I mentioned, it has also been implemented at the University of South Florida. They implemented a pilot with med students and residents, so a little bit of a broader range. They're in process of analyzing their data, and hopefully it will show that this is also feasible to do with residents and the results are generalizable. Perhaps in some ways what we're most proud of is when we implemented this adept care module with the Penn State Health patient-facing staff, excuse me, all patient-facing employees at Penn State were invited to participate. Now, I'm not sure about you guys, but I know I get a lot of emails every day asking me to do things. So I wasn't really sure how this was going to go because these healthcare employees get a million emails asking them to do a million trainings. And I want to stress that when they were offered the adept care protocol, it was voluntary. They did not have to complete it, and it was sent to 14,000 people. 91% or over 13,000 of our patient-facing employees completed this training, which is just crazy to me in the best way possible, but it shows that healthcare staff want this training, and if we provide this training, they will do it. And we received great feedback. We're really excited to analyze those results. And the strength of this is that we have these videos recorded so they could be completed asynchronously on these people's own time, which is really important because we have people working a variety of shifts across our healthcare system. So it's not really feasible to get them all in one room. And so our current state, as I alluded to, is all first-year medical students, all second-year med students, and all first-year physician assistant students at Penn State are receiving some sort of mandatory session related to adept care. And how has this affected us? So amongst the first-year medical students in our pilot study, all or 100% of participants agreed or strongly agreed that they will use adept care to assess patients with disabilities, that adept care will help them to take better care of patients with disabilities, and they desire to receive more training on disability. And when we surveyed our patient-facing staff, nearly all participants agreed that the adept care module increased their confidence in caring for patients with disabilities, improve their knowledge of disability health, and will help them take better care of patients with disabilities. And so there's been a lot going on. So just to recap, our pilot results with the students were really promising, and we were able to publish that research. The UCF, the University of South Florida, did their pilot study as well, and their data is currently being analyzed and written up into a manuscript, which will hopefully be published. We're in process of assessing if the adept care results are generalizable to other healthcare profession students for example, the physician assistant students. So we've collected that data, and that's in the process of being analyzed. And then we're also assessing if this is efficacious and generalizable to practicing healthcare professionals and the patient-facing staff. So we've collected that data. I shared some results with you, but we have more coming. And most importantly, we are continuing to promote Adept Care as a valuable teaching tool through things like this presentation. It's really important to our team to be collaborative, and our ultimate goal is just to improve healthcare for patients with disabilities. And so it's important for us to publish and talk about this as a way to disseminate this information. And this is where we are now in the evaluation phase. And so next steps, we're evaluating the data with the physician assistants and writing that up. We're evaluating the Penn State Health patient-facing staff data, and we're in process of developing a longitudinal evaluation. So we love that we have the pre-post data to say, hey, this intervention worked, but with much educational training and research, there's a need for longitudinal data evaluation. So do these results persist 6 months from now? Do the students still remember this 6 months from now? Are they actually implementing this in their clinical environments? We're also developing the phase 2 videos with the focus on the PEDS population and patients with IDD through our partnership. We're developing or ensuring that this curriculum is sustainable. So one way of doing that is implementing it into the mandatory curriculum so that it continues to be a recurring thing for all medical students. And then trying to disseminate the curriculum, both through research, community presentations, partnering with others. And so in summary, our goal was to develop, pilot, and evaluate a novel teaching mnemonic, Adept Care, for performing a comprehensive history and physical exam for disabled patients. This directly fills a reported gap in medical education by addressing students' discomfort with performing a history and physical exam for patients with disabilities. Through our research, we have shown that Adept Care has the potential to be easily understandable as a teaching tool, and it can be effectively and flexibly implemented into medical education in a variety of settings. So here is my contact information. And I saw somebody asked about I will post the link to the publication in the chat directly. I will mention that you probably have to log in with your institution. So if you want a PDF of it directly, you can email me and I'll send you the PDF directly. And I'd love to share this with more people. So thank you so much for having me.
This is Rhonda. Lydia and Shane, thank you both for your leadership in health equity for individuals with disabilities. And also thank you both and extend our gratitude to your colleagues for demonstrating how championing health equity is something that each of us can contribute to, and that we can make differences that ripple like you demonstrate. My goodness. Shane and Lydia, any closing comments from you before we turn to Sherry to close today's webinar?
Just a comment. So I just actually yesterday afternoon, just to kind of put this work like into tangibly what it could be for the healthcare delivery field. So I went to a podiatry appointment with my brother. He has severe intellectual disability and requires 24/7 supervision. The podiatrist has 2 daughters with Down syndrome. And we were referred through this network of people from the Fab Center and all the other friends that are all well connected, and just finding a podiatrist with that experience who brings their personal experience into the work for the patients that they want to see makes a difference. Like just the appointment itself, you can clearly see the difference between had we shown up at, a podiatry office that doesn't have that experience. It's very evident. And otherwise my brother probably doesn't even get through the appointment. So we're there because he doesn't let us touch his toes. And we got through that, and it was all good there. And it really is that level of rapport, the social interaction. It's all the same care being provided, but you see the difference even in, the 15 minutes that we had a chance to spend with the physician there. And again, connected to all the people that this group is connected to. So specialists are kind of being more, becoming more well-known among the network as well. So we're excited to keep growing this and keeping everybody like on the same page as this evolves and see where we can take it. So just this type of work, having this experience in action, my family just had a chance to have a good interaction with some healthcare providers yesterday, which was great.
Thank you, Shane. One of my favorite definitions of inclusion is the concept that through relationship with others, their experiences are included within you as a person and in your walk in life. And you gave such a good example of that in the experience that you recently had. Thank you. Lydia, any closing comments from you before we turn to Sherry?
Sure. I would just encourage everyone here to keep having these conversations. I feel like I've been fortunate to have opportunities just by telling people what I care about and what I want. And so many times I talk about it and someone's able to relate through their own personal experience. And we wouldn't have had that conversation if I hadn't been so forthcoming with my passions. And I feel like especially as students or as women or whatever identity you occupy, there's a tendency to want to hold things that are close to you. And I think just as you said, those experiences become part of those around you. So thank you all for the work you're doing. And I encourage everyone to keep doing this work in all of the spaces you occupy so we can make the world a little bit better.
Thank you for inspiring us and doing just that. Thank you. Sherry.
Wow. I'm going to quote Lydia. Let me see if I can find it. Lydia, I think that you summed this work that we're all doing so well. It says, this advocacy work is difficult, but we can all make a difference. No matter what your role is, it's not too small. And I think this is really a great summation of the work that we've all been doing for the ARC of Pennsylvania and our partners in this grant, the COVID-19 Health Disparity Grant. But it's amazing to us because before we started this work, we felt that we did not see what other people are doing, whether it's across the country. I knew what Shane was doing. I knew what Achieva was doing, but this work has, through this work, we've been able to see more of it, but also we're also seeing really changes and policy discussions happening on both the federal level, excuse me, and a state level. I just received in my email while we were talking, and it is public comment period now open. Keystones of Health, Pennsylvania's proposal to address social determinants of health has been announced. Department of Human Services announced a proposed initiative that would create a new section 1115 waiver demonstration program in Pennsylvania aimed at addressing social determinants of health as a way to improve health outcomes. I mean, we don't get more timely than that, right? Please comment. We need to make sure that all our voices are heard with the department on this critical work. And then we will also be working with the Department of Health. So this is good news. We are making a difference. Shane, Lydia, thank you so much for all the work that you've been doing. It is, I'm honored to be partnering with both of you on the projects that you're doing. So thank you. So on March 6th, we will be hosting our first ever health summit. We are going to be releasing a new project that we hope to announce at the time. And we'll be telling everyone about that, but we're also focusing the health summit on the core recommendations, and speakers are aligned with the core recommendations. So please look for more information at the beginning of the year. We'll have that on our website. We will also send it to all of you, because if you shared your email address with us through the registration process. Then also our partner, the Department of Health, will be having their 2024 Health Equity Summit in Harrisburg on April 4th and 5th. So the year 2024 is the year of raising awareness around the health disparities among people with disabilities. So I hope you can join us for both events.